Welcome to the explainer. Okay, so your patient comes in with new weakness or some strange sensory changes. You know the clock is ticking. What you need is a really clear, solid framework to work through the possibilities, and that's exactly what we're going to build together right now.
So here's our game plan. First up, we're going to learn how to spot the signs of myelopathy in the first place. Then we'll dive into the two big categories of causes. You've got things physically pushing on the cord, that's compressive, and then problems happening inside the cord itself. And we'll wrap it all up with a practical playbook you can actually use on your next shift.
All right, let's start at square one. How do you even know you're looking at a true neurologic emergency involving the spinal cord? What are those telltale signs that should make you sit up and pay attention? You know, this is one of the most common and, frankly, high-stakes questions we face in medicine. Getting this right is critical because when you're dealing with the spinal cord, time is function. Any delay in diagnosis could lead to permanent, really devastating consequences for your patient.
The key term we're going to be using is myelopathy. It's really just a catch-all for any disease of the spinal cord. It can come from something on the outside pushing in, like a tumor, we call that extrinsic, or from a problem within the cord itself, an intrinsic cause, like inflammation. Recognizing it fast is everything because you're trying to save all that vital anatomy packed into such a tiny space. Now, this is where your physical exam is just so powerful. This slide lays out the two classic patterns of injury beautifully. Is the problem high up, in the spinal cord itself, hitting those corticospinal tracts? Well, then you're going to see upper motor neuron signs, spasticity, brisk reflexes. Or is the problem lower down, affecting the nerve roots of the cauda equina? Then you're looking for lower motor neuron signs, flaccid tone, no reflexes. This distinction is your first and most important step in localizing the problem.
But hey, it's not just about motor signs. You've got to be a bit of a detective here and look for these other clues. Things like a really clear sensory level where sensation just stops, a change in how they walk, this weird banding or squeezing feeling around their torso, or of course, new problems with their bowel or bladder. These signs are so easy to miss or just blame on something else. Okay, so now we know what to look for. Let's talk about what's causing it. And we have to start with the most time-sensitive category, compressive myelopathy. This is when something is physically squishing the spinal cord, and it is a true surgical emergency. These are the red flags that should be setting off alarm bells in your head. Patient has a fever and very specific, localized back pain. You have to be thinking about an epidural abscess. Do they have a history of cancer? You have to suspect metastatic disease is spreading to the spine. And if they're on anticoagulants, an epidural hematoma has to be on your list. These clues from the history are your trigger to act fast. And this MRI, wow, it shows us exactly what's going on in metastatic cord compression. Just look at how that vertebral body has completely collapsed. You can see the bone fragments literally pushing back and squeezing the spinal cord. This picture tells the whole story. It's the anatomical reason for the patient's symptoms. So the take-home message here could not be simpler. If you are even a little suspicious of a compressive cause, you do not wait. Neurologic function can go downhill so fast. You need to get an emergent MRI of that part of the spine. And the second you've confirmed metastatic cord compression on that MRI, the playbook is clear, and it starts immediately. Step 1, high-dose glucocorticoids to hammer down that swelling around the cord. Right after that, you're making an urgent call to neurosurgery for a consult, and then you're planning for radiotherapy. Okay, let's totally switch gears. What if that emergent MRI comes back and shows nothing? No compression at all. Well, now we have to think about non-compressive causes, where the problem is actually inside the spinal cord tissue itself. A huge player in this category is idiopathic transverse myelitis, or ITM. Basically, this is an inflammatory attack on the spinal cord, often triggered by a recent infection or virus. It's usually monophasic, which just means it's a one-time event. Patients will present over hours to days with weakness, sensory changes, and often bowel or bladder problems. This MRI shows the classic finding in transverse myelitis. See that bright white signal that the arrows are pointing to? Yeah, that's not supposed to be there. That is inflammation and swelling directly inside the cord. This is what an intrinsic cord lesion looks like, completely different from that compression we saw earlier. So treatment is all about stopping that inflammation, and we usually do that with high-dose IV steroids. But, and this is a really critical point, you absolutely have to rule out infectious mimics first. Things like varicella zoster, syphilis, even HIV can cause a myelitis that looks just like this, and treating one of those with steroids could be a total disaster.
All right, so beyond direct inflammation, we also have to keep metabolic problems and vascular issues on our radar as other potential non-compressive causes. Okay, here is a classic clinical picture you have to lock away in your brain. If a patient comes in with this weird combination of upper motor neuron signs, that's spastic weakness, and a loss of their dorsal column functions, like vibration and position sense, you have to think about subacute combined degeneration from B12 deficiency. And here's a pro tip. If the B12 level comes back normal, check for a copper deficiency. It can look exactly the same. And this is a perfect example of why localizing is so cool. If a patient has a sudden, almost stroke-like paralysis, but when you check them, their vibration and position sense are totally intact, that points directly to an anterior spinal artery infarct. The specific pattern of what's lost and what's spared on their exam tells you exactly which blood vessel is in trouble. All right, let's pull all of this together now. We're going to synthesize everything we've talked about into a super high-yield review. That playbook that you can take with you right to the bedside. First things first, always start with your exam. Telling the difference between upper and lower motor neuron signs is your fundamental first step. It's how you start to figure out if you're dealing with a true myelopathy or a problem with the nerve roots instead. Next up, always screen for those red flags in the patient's story. A known cancer history, a fever with very specific spine pain, these things should immediately make you worry about an urgent compressive cause that needs your immediate attention. Your diagnostic go-to is pretty clear. It's the MRI. When you suspect a myelopathy, especially a compressive one, an MRI of that area is the test you need. And remember, when those red flags are flying, that MRI needs to happen emergently. And finally, if you do confirm metastatic compression, remember that treatment algorithm. It starts right away with steroids to buy you time and calm down the swelling. And that's followed by getting your surgical colleagues on the phone immediately. And that really brings us to our final and maybe most important thought. We've been so focused on the acute diagnosis and treatment, but we have to remember that for these patients, that's often just the beginning of a very long journey. The speed and the accuracy of your initial workup has a direct impact on what's possible in that next crucial phase, intensive rehabilitation. Maximizing their long-term function and quality of life starts with the steps we've just outlined today.